Hello, I'm Petros Grivas. I'm a medical oncologist at the Seattle Cancer Care Alliance and associate professor at the University of Washington and Fred Hutchinson Cancer Research Center. We're very excited and thrilled for the results of the JAVELIN Bladder 100 trial that Dr. Tom Powles presented at the ASCO plenary session just a couple of days ago. And these results of this study, in my opinion, are practice changing. So let me review this presentation by Dr. Powles and then make some comments as we go through this, just to orient the audience and make some particular discussions regarding the practice implications of this data. As I mentioned, this was presented on May 31st by Dr. Powles at the plenary session of the ASCO 2020 virtual meeting. There is no doubt that urothelial cancer is a very challenging condition, and is the most common location of urothelial cancer is bladder. So bladder cancer is the most common location, but urothelial cancer can arise from other parts of the urinary tract, the renal pelvis, the ureters, and the urethra, but bladder is the most common location. Bladder cancer is the most common, one of the most common, I would argue, cancers overall. Is the sixth most common cancer in the US and responsible for about 200,000 deaths worldwide in 2018. Despite that, many patients get frontline chemotherapy for metastatic urothelial cancer. The responses to this frontline chemotherapy depend on the chemotherapy regimen, and they're about 50 to 60% with cisplatin-based chemotherapy, and between 35 and 40% with carboplatin-based chemotherapy. And even for the responders, the duration of response is not that long. The median progression-free survival is about 7 to 8 months, and patients then get second-line therapy. The problem is there is significant drop-off between the first and the second line, and patients, because of clinical deterioration, declining performance status, access to care in other regions, may not be able to get second-line therapy. And about between 25 and 55% of patients, based on the literature, are able to receive second-line therapy. So there is clearly a need there to capture the patients who have response or stable disease, do frontline induction chemotherapy, and see if we can maintain those that clinical benefit, those responses or stable disease situations. And of course, as we all know, outcomes in the second line beyond therapy remain suboptimal, usually with rapid disease progression, even in those patients who achieve response with second line therapies. PD-1, PD-L1 inhibitors have been standard in the second line setting after progression to frontline chemotherapy. And these agents include avelumab. There are 5 of them approved. And right now in the United States, we have 5 FDA approvals in this platinum refractory setting. Although those agents have significant anti-tumor activity, the overall response rates with PD-1 or PD-L1 inhibitor in the second line setting is between 15 and 21%, depending on the data set. So there's definitely a need to improve upon those response rates, and only a minority of patients get a durable benefit with second line therapy. So there is, as I mentioned before, a clinical unmet need to try to capture patients earlier before they progress after frontline induction chemotherapy. And in that particular context, this JAVELIN Bladder 100 trial was designed in order to answer the following question: if the patients have no progression after the frontline chemotherapy, do they benefit from immunotherapy in the switch maintenance approach? And as you see, this is a very attractive strategy, because if you have no progression on frontline chemotherapy, then this disease control that was already achieved by chemotherapy would set the stage for immunotherapy success, because immunotherapy could potentially work better in this disease control situation versus in a situation of progressing cancer. That was the hypothesis and the assumption. And also initiating immunotherapy before progression may capture more patients, as I mentioned before. There are some other reasons why we designed this study. We thought that chemotherapy could potentially result in disease control, but also possibly in immunogenic cell death. And then if you follow up with immunotherapy back to back, you might potentially have significant clinical benefit. And that's how we designed the study. As you see in that slide, and Dr. Pauls presented all this data at ASCO plenary session, this is a randomized phase 3 clinical trial with 700 patients who already had received platinum-based chemotherapy, as you see in the slide, and they had a response or stable disease on restaging scans after the end of chemotherapy. And there was a time window between 4 and 10 weeks after the end of chemotherapy, the last dose of chemotherapy, until the patient was enrolled in the study. And the patients were randomized to avelumab, anti-PD-L1 checkpoint inhibitor, plus best supportive care versus best supportive care alone. And the primary endpoint was overall survival in all comers, as well as in the subset of patients with PD-L1 positive tumors. Secondary endpoints, including progression-free survival, overall response rate by RECIST 1.1, safety and tolerability, as well as patient-reported outcomes and quality of life, which is a very important component. Statistical design, as you see in the slide, the type 1 error rate was maintained at or below the one-sided 0.025 by splitting the alpha and allocating 0.015 and 0.01 alpha to overall survival comparisons respectively. As you see, in the overall population in all comers, as we call it, it was estimated that 425 events would provide 93% power to detect a hazard ratio of 0.7 at the significance level of 0.015. And we had similar assumptions and designs for the PD-L1 positive population, as you see in that slide, with 219 events providing 80% power to detect hazard ratio of 0.65 at significance level of 0.01. So the primary endpoint, as I mentioned, was all comers and also the PD-L1 positive tumors in this patient subset. And a planned interim analysis was performed after 324 events. That was about 3/4 of the fraction of the information that was expected in the overall population, and 143 events. That was about 2/3 fraction of the PD-L1 positive population events based on the statistical design. And as you see, we had efficacy boundaries for overall survival in the overall population and the PD-L1 positive population with p-values as shown in that slide. The baseline characteristics, as you see, the median age, the site of primary tumors, visceral disease distribution, as well as chemotherapy regimens, and the proportion of patients with response or stable disease, you can argue are relatively balanced between the two groups, and avelumab plus best supportive care or best supportive care alone. And as you see also, there is a significant balance as well in those characteristics in the PD-L1 positive patients, in patients with PD-L1 positive tumor, to be more accurate. As you see, the proportion of patients who discontinued therapy because of progressive disease was 54% in the avelumab arm and 75% in the best supportive care arm in all comers. And as you see, disease progression was by far the most common reason why patients came off study therapy. This slide shows the primary endpoint of overall survival in all comers. As you see, the median overall survival was 21.4 months in the avelumab arm and 14.3 months in the best supportive care alone arm, which is 7.1 months difference in the median overall survival, with a stratified hazard ratio of 0.69 and a very significant p-value less than 0.001. As you see, the curves separate early. I would argue here they separate, in the first few months, probably at the time of the first few scans, and then stay separated all the way until the last follow-up. So there's a clear difference, as you see, in the overall survival in this all-comer population. This is the overall survival in the subset of patients with PD-L1 positive tumors. I want to say here that PD-L1 positivity was measured by the Ventana SP263 assay. It's important to point out, as I mentioned, that there was a balance in the two arms regarding the PD-L1 positive populations. In this particular population, you see a significant overall survival benefit. The hazard ratio 0.56 with a very significant p-value less than 0.001, with a median overall survival not reached yet in the avelumab arm and 17.1 months in the best supportive care alone arm. This slide shows the subset and subgroup analysis of overall survival. As you see, pretty much all the subgroups appear to benefit from the avelumab arm. As you see, all of those bullet points you see here with blue are on the left, favoring the avelumab arm. Of course, there's some subset with very small sample size, as you see here, but I think there's a consistent message that all the subsets here benefit with the avelumab arm. Progression-free survival was also favoring clearly the avelumab arm. There was almost doubling of the median PFS from 2 months to 3.7 months, with a hazard ratio of 0.62 and a p-value of less than 0.001. And this was by independent radiology review committee in the overall population, with the curve separating early on, I would argue, at the time of the first scan onward afterwards. And this is the PFS data in the PD-L1 positive tumors in this patient subset. As you see, there was a significant difference of the PFS here. Again, hazard ratio 0.56, median PFS 5.7 versus 2.1 with a very significant p-value, and very early separation, as I mentioned at the time here, 2-month time point, the curve separate in favor of avelumab. Overall response rate, as I mentioned before, in other settings and conversations, is not a very, I would say, relevant endpoint in a maintenance trial. Despite that, we went ahead and we looked at the overall response rate, and as you see, this was about 10% with the avelumab arm, 1.4% in best supportive care overall population, and the number here is a little bit higher, PD-L1 positive patients, about 14% versus about 1%. Again, this corroborates that you may still have responses with checkpoint inhibition after chemotherapy, and I think the team was very conservative in this number here, based on the denominator of patients who had disease that could be measurable, and the overall response rate could be measured in that case based on RECIST 1.1 criteria. I think these numbers, again, are not something we need to focus on too much in a maintenance trial, but definitely show that the responses can be attainable with this agent. And the denominator, as I mentioned, is relevant because if you include patients with not measurable disease, you may have a larger denominator, and this can reduce your response rate. Subsequent therapies is a very important point. As I mentioned before, this proportion of patients who got subsequent second-line therapy in the best supportive care alone arm was 62%. And from all those patients, 44%, about half, got PD-1 or PD-1 inhibitor as second-line therapy. And that, I think, is relevant and consistent with what we have seen in the literature so far, and not very different compared to what Dr. Galsky reported in his switch maintenance trial with pembrolizumab versus placebo that was reported at ASCO 2019, the Hoosier study. So again, I think these numbers here are not far from what is happening in real world. However, we all want, to salvage our patients and try to, provide them access to checkpoint inhibitors in the platinum refractory setting. But as I mentioned before, some patients may not be able to get that. because they have a rapid decline in performance status and disease progression. A small proportion of patients got other therapies, as you see here in this particular slide, and some other drug here. This may include also other chemotherapies. Treatment emergent, not related adverse events, meaning of any cause, treatment or not, as you see in that slide, were common in both arms. 98% with avelumab and about half of the patients on best supportive care. Again, this is emergent, so any causality. And the treatment emergent adverse events that led to discontinuation of avelumab was 12%. And as I mentioned, the overall profile of this drug was relatively safe and manageable and consistent with what we know about checkpoint inhibitors in this particular metastatic urothelial cancer setting, and there were no new safety signals in this particular trial. So safety and tolerability consistent with prior data. Here are data regarding immune-related adverse events. As you see, of any grade, there were about 29% with avelumab, and specifically on grade 3 or more were 7%. Again, consistent with what we know about these agents. There were no grade 4 or 5 immune-related adverse events. And as I mentioned, the management of those adverse events was consistent with the management we do with immunotherapy in other studies. To conclude, JAVELIN Bladder 100 trial met its primary endpoint by showing significantly longer, I would argue both statistically and clinically, significantly longer overall survival with avelumab first-line switch maintenance therapy versus best supportive care alone, both in all comers and in the subset of patients with PD-L1 positive tumors. Overall survival was longer with avelumab versus control across all the pre-specified subsets. And this includes cisplatin or carboplatin-based chemotherapy and response versus stable disease, as well as I mentioned previously, patients with visceral or non-visceral disease appear to have benefit from this agent. The safety profile was consistent with what we know from checkpoint inhibitors. And in my opinion, this is a new standard of care. This is practice changing in patients who complete frontline chemotherapy and they have no progression. I think avelumab has level 1 evidence based on this trial. Of course, we have to wait for regulatory review and to see what will happen there. But I think this difference is very hard to achieve and definitely, I think, worth noting and in my opinion, practice changing. Nothing can happen without the amazing effort from our patients and their families. So kudos goes first to them, patients and families and caregivers. Of course, multiple investigators across the globe. As you see in that slide, we had multiple investigators from different countries and nothing could happen without their support at each participating center and also their research staff. So congratulations to all of the investigators. These are Twitter handles from Dr. Pauls, who did this presentation in a very elegant way at the ASCO plenary session of 2020, and my Twitter handle, and we're happy to answer questions also in social media and other forums. And I would like to thank everybody for attending ASCO, Dr. Paul's presentation, and also attending this webinar here. Just to conclude, I will just make another comment that clinical trials are very important, and this is the way we move forward. There was an excellent discussion by Dr. Klimak at the end of the plenary session that actually made excellent points, and I would also recommend to the audience to look at that discussion by Dr. Klimak and also continue accruing in clinical trials in the future. That's the way we can make progress, and that's the way we can also learn about the biology of disease and look at biomarkers, because in the future we want to pursue more individualized therapies, and we keep going in that effort. And this trial is a great example of how we can make strides and progress in this challenging disease. Thank you very much.